Thank you. So it really is a pleasure for me to be here. As many of you know, it's a very rare occasion. I basically don't exist in the pediatric cardiology community very much anymore because I've moved to other things. But it is nice to have rare appearances. Yes, I think that's very nice. So I was asked by Felix Berger to give a talk about the almost 20 years now of the Melody valve, and he was kind enough to give me a very, very open topic because I know much less about the Melody valve in clinical practice than you do by now. And but still, obviously, there are certain thoughts about it. He said, the second part of my title, what have we learned? And I thought I would modify that a little bit to what I have actually learned about that, or what are the take-home messages I had in this entire experience, which was very significant, obviously, in my life and in my thought altogether. So what I'm going to do here is to give you a little bit of a personal account on what I learned from the pulmonary valve. And sorry, I think I changed the slide with my rather large belly here, excuse me. Okay, so here, what I did was to prepare this talk, I was just looking back a little bit into what happened and how that happened. And I actually had a few ideas before the Melody valve, which brought me into contact with industry at the time, and that was certainly a very essential part of getting the possibility later to develop anything, because I think one can easily end up with some type of idea, but then not have the connections to kind of make anything out of them. So my contact in the beginning with industry, in particular with the company NewMed, was very, very relevant. Then there was the idea of the Melody valve. Obviously, that's why we're here today. There was a lot of thinking about the regulatory strategy, and I'll get into that. Also about the various first-in-man experiences. And I certainly had quite kind of an interesting relationship with industry altogether and learned something about business. I never thought I would learn about business because I wasn't so very interested in that, but it was unavoidable to a certain degree. So I have thought very much, and that is actually somehow triggered by Johannes, who just gave the introduction, why ideas come up and who comes up with ideas. I remember a particular conversation I had with Johannes years ago, which made me think more than he would think, and I mean, about this particular topic. And I've actually given talks about that in the past. So how the ideas come about and how ideas become successful is really something I'm very interested in, but I'm not going to talk much about that. I will talk today more about the idea of what one actually needed to invent in order to get where we eventually got altogether. So I will then touch on these other aspects of the collaboration with industry, very little actually, but what I think the role of consent would be for first-in-man procedures, and then a little bit about personal bias also. I will pick up out of a talk I prepared some time ago, and I apologize for those people who have seen that already, from which I will develop things. I would like to talk just a little bit about why ideas very often probably do not develop. And for that, I'm going to tell you two stories some people of you know, but I will do that anyway. And the first story here is true, which might make you understand that the second isn't. Let me go through the true story at this point. So the way Melody valve actually developed was through the fact that I had an idea in the late 90s, and I was working in an animal laboratory in Paris at the time. Approximately 18 months later, there was another group who was led by Alain Cribier, starting to do aortic valve implantations, and that was in the same animal laboratory in Paris. After my first experiments, I was granted approval to make the first valve implantation in September 2000, so now 17 years ago. It really is almost 20 years. And 18 months later, the first aortic valve was implanted by Lange. The pulmonary implantations, I don't know how much you followed them at the time. Many of you weren't even around. They went well. We didn't really have big problems, whereas the aortic implantations were quite complex and did not go so well. With the pulmonary program in 2004, we had 50 pulmonary valves implanted, and there was, at that time, no mortality, no procedural mortality, no mortality in the follow-up. With the aortic valves, it didn't go quite like that. There were 20 aortic valves implanted, and there were only 7 survivors at 3 months. So these were very different numbers. And the French regulators at the time stopped the aortic program because this was considered not good enough. 2005, I was actually chairing a meeting at TCT where they presented the first 2 core valve cases, to be honest, as a success, but both of the patients had died. In 2005, that was a year later, the pulmonary experience was then with 100 patients, still with no procedural death. And core valve then at the Transcatheter Valve Symposium in 2006, then presented 11 patients, and there were only 4 survivors at 1 month. So these were difficult things. The aortic valves were not going so fantastically well. On the other hand, I mean, there were some good points why that was so complicated with the aortic valves. They had really, I mean, these patients didn't have alternative treatment available because by definition they were not surgical candidates at the time. They were a very fragile patient population, and there was this background of the pulmonary valves which were successful, and therefore the regulators decided that they would allow again to continue with the aortic program. And they did a good thing with that, because you know how many patients have now been treated with the aortic valve implantations, and it actually works by now. The mortalities are low, and here I say it's more than 10,000 cases. I actually don't know, it's many more than 10,000 cases on a yearly basis. So it was a good decision to go ahead with the aortic valve, but it was a difficult one without a question. Now I'll tell you a second story, and that is an invented story. So here I do a theoretical little attempt. I just change dates. I put the aortic valve in front of the pulmonary valve, just as a little mental exercise. So it would have started with the pulmonary valve. Everything would have been the same, but after the first aortic experiments, ethical approval would have been granted for the aortic valve at that point. Then first aortic valve would have been implanted. All the pulmonary stories wouldn't have happened at this time. If one goes on, the aortic implants would have been problematic as they were. I mean, why would that be different in any way? And ethical approval for pulmonary valve would not have been given based on the problems with the aortic valve. I mean, why would one allow to use a pulmonary valve if there are so many problems with the aortic valves? And one would have shown the same results. I mean, pulmonary valves wouldn't have been done. The aortic results would have been shown. French regulatory agencies would have stopped like the same time. Then the bad results would have been once again shown with the, at TCT, and then the core valve cases at TCT would have probably given the entire end to the story, and after careful considerations, the regulators would have stopped all valve programs altogether. So what I did here was just changing 2 dates, and the ideas would have been exactly the same, and the entire technology of valve implantations could have ended at this very point. And if you look at, I was saying in 2020, somebody else would have tried it once again, one would have said that you go to your boss and you come up with this nice idea, and then one would simply say, these things you can do in a circus, but don't do them in patients because you would kill them. So that would have been the definitive end of such a technology. It is interesting to see that in history you find some examples like that. It was found that X-ray could cure cancer in 1899, and that it could cause cancer in 1902. Just switch that and play through this particular scenario. I think it's interesting. So, sorry, I was going in the wrong direction again. So now I would like to go on with these concepts and would just say, what did we actually need to invent? Well, the order in innovation, it's normal that you identify a medical need, and for example, pulmonary regurgitation was maybe a not really addressed problem at the time. You would search for solutions. In that case, it would have been the non-surgical valve. You invent a device, the Melody valve, and then you do the regulatory, the industrial development, and whatever. But it doesn't go like that. It would be really nice if you could do it like this, but actually the order happens in a very different way. Here, that is what really happened. There were covered stents which were beginning to be used, and I was involved in a case of covered stents, and they said, if you can put something around a stent, why shouldn't it be possible to put something inside a stent? And then I tried some things and very quickly came to this thing. After that, I had to make the next invention. I needed to invent the disease. Now I had the device, but the disease didn't really exist. And you might kind of find that slightly amusing, but that exists. If you look at these Peter Dunn and Albert Wood, I don't know who of you knows who this is, they worked on a very, very difficult name here of a drug with which one could do vasodilations and so on, and which was meant to be a drug for an angina. And they found rather embarrassing side effects. And here one needed a genius. One said, if one has embarrassing side effects, what can one do? They invented a disease, which in cardiology is not so well known, but which ED stands for erectile dysfunction. And that was the story of Viagra. So Viagra was invented out of a failure of a pharmacological development. So if we look back in the year 2000, pulmonary regurgitation was not a disease which was taken particularly seriously, and we probably have changed our attitude towards that. Well, we've been there. Now, what else did we need to do? Now, we had this little device, and we actually needed to invent a regulatory strategy. Now, that is something which one does a little bit oneself, but that is actually very much what the collaboration with industry is in the beginning. You have to understand that you're faced with the FDA. No serious industry will invest into technology if they can't overcome the hurdles of the FDA. And the FDA at the time had just published a heart valve guidance document when we came with the first transcatheter valve, not a surgical valve. And that document was written 800 pages in 1994. We came 6 years later. And they made all kinds of statements of how it needed to be tested, a valve. Obviously, always thinking about surgical valves, needed to be safe and effective as compared to currently marketed replacement valves and so on. And they put in these 800 pages so many hurdles that we really could not do that with Melody valve. We could not overcome the hurdles. We could not really be comparable to the surgical valves. But we stood in front of a document which was close to being law, actually. So how can you convince the industry that you should do that anyway? Because I told you that industry will not give you a clearance for any type of investment if the regulatory hurdles are unsurmountable. That's just not something which can be done. So one needs to invent something in the regulatory strategy, and we did. We just decided that the Melody wasn't a heart valve. Melody was not a replacement valve, and we said if it's not a replacement valve, then we don't have to read this heart valve guidance document. So the heart valve guidance document turns out to be the wrong book to read. That was somehow an invention which was necessary. We just said that the Melody was a device to prolong RV to PA conduit life. So this was the device. It wasn't a heart valve. It was something which would prolong conduit life. Pure invention, just semantics. But that was what allowed us to not read the heart valve guidance document. And that was the basis of the regulatory strategy, which ultimately allowed to get the FDA approval, which happened then in these various grades. But I never really understood what these things mean, but there are some people in this room who understand that very well. Now, the next thing, so this is, I was talking about the things which I think one needs to invent kind of surrounding the original invention, let's say. But there are other issues which influenced me as a person very much, and I thought about also quite a bit, and that is how would you consent for first in man? We all know that consenting is a delicate thing, an impossible thing. One should be able to explain to people what one is actually doing when one doesn't necessarily understand it oneself in every detail. And the consenting, in particular for first in man, to me is a challenge and has certainly quite a number of important ethical dimensions. But I was lucky in my second approach to these pulmonary valves, when we started with the first infundibular reducer, or whatever one calls it now, device, and that was in 2009, where we implanted in a device in this patient, Simon, who was is a very intelligent man and an engineer. He a little bit more than about 42 years of age, but he was an engineer and he could really understand what we were technically doing. And we asked him whether he was willing, and I mean, obviously the question is, how far do you go in kind of an honest representation of what you do? And he agreed to have a video recording done of this consenting, and I proposed that because I found it interesting to film such a consenting episode, and told him that I would like to give it to him so that he is afterwards legally protected, because he could say that I didn't say something at the consenting. So it actually gave him a legal strength, but he was very happy with that. We had a good relationship. So there are obviously the aspects that there is a big step to make from the animal experiments to the first in man, and then there are other things. One is inexperienced, there's conflict of interest and other things. So here I would just like to show you some little parts of this tape of how we approached that at the time.
Now, when we go for consenting like this, we're in a very different situation from the normal consenting, because usually when one consents, one bases the assessment of risk on previous experience, personal experience, and also experience which comes from literature. Now, for you, we don't have that. We have no proper clear idea of what can happen, because the step we are making from the experimental field into the clinical field is a big one, and we know that. We know it's a big one. And therefore, when we do a consenting basically on guesswork. We try to guess it as well as we possibly can, but we have certainly not percentages we can quote, but we have a rationale behind it, why we think it is the right thing to do, and we'll obviously go through this rationale.
So, here I was relatively open in front of him. I was at the time thinking that I would like to get a legal opinion, how far I could go in these things. And then I said, if I ask somebody, they'll tell me not to consent like this. So I didn't ask and just went on. So you will hear a second expert here. Oops, I don't know about this.
Which are...
Sorry, I'll try to give that to you once again.
The things I would like to get out of the way are kind of some technicalities which are important. One is conflict of interest. Okay, conflict of interest is I have been considered, or am the inventor of the pulmonary valve implantation, and I've developed this first melody valve with which there is experience, and we'll get back to that, but also of this particular device. And since I am inventor, I have patents on that, and since I have patents, I will have rights to that, and would theoretically, if this becomes a successful project, be receiving royalties for these inventions. Therefore, I do have a conflict of interest of financial, with a financial background. Not on your specific case, because this is not a commercial product at this point, but it will be. So, I mean, clearly, yes, there could be a bias. which I think is important for you to know.
So this was a statement, if it works on you, I'll be a rich man, more or less, and which I think is, by the way, it hasn't developed as fast as I would have hoped at that very point, but I think is probably something which could be introduced also in the consenting. Here another example.
Next step, which is a fundamental kind of philosophical problem, is we are going to go into a procedure where the outcome can be good, this is what we hope, it can also be not good. We are obviously in a position that there can be something which went wrong. Now the question is, what do we call it if it went wrong? I mean, can we say it's bad luck? And I would state very strongly that no, it won't be bad luck. It will be, we can call it our ignorance, which is because we couldn't foresee some type of problem we ran into. Now you could say if we produce the problem and we afterwards understand how we could have avoided it, then we can call that, in my word, a mistake. Now it's not an intentional mistake, but it is a mistake which can be understood or kind of recognized as a mistake only once it happened.
So the question obviously was how, I mean, legally, and that was the question I had to the lawyer, which I then actually never asked. Can I say that I will make mistakes? Which was obviously the experience I had from the melody valve. And I believe that, yes, one does make mistakes and one should admit to them. And if that gives a legal trouble at a later stage, then that's fine. So here, I think the last example.
Now that I know that in the experience I'm going to make with this particular device, and you and others will include mistakes I'm going to make. I know that.
So I said at that point that mistakes would happen, and I still think that it should become very clear that whether first in man or not, that these things are kind of human error is something which should be allowed in medicine, like it is allowed anywhere else in pretty much every other profession. Anyway, so I have come to the end of my presentation here. I think these are the things which kind of interested me out of this experience with in the last, let's say, 17, 18 years. One was involved in that, and I obviously know that personal bias is something one cannot really take out of the equation, and I'm also not immune to, like others just not immune to. I somehow do hope that I didn't invent a disease. Thank you very much.